Thank you, Nam. You're getting my slides? Are you getting my slides?
Yes, ma'am.
Okay. So thanks for inviting me to be a part of this symposium. And I'll be speaking on viral keratitis and attaining the right balance as to we see number of cases where when antiviral needs to be given, the steroid is being given, or when proper systemic antiviral is to be given, something else is given, or maybe a viral is mistaken as bacterial. So I really titled the talk as attaining the right balance. Viral keratitis is very, very specific as it differs from my earlier speaker. They talked about bacterial and fungal keratitis, and it is chronic and it is recurrent. The important thing is it is recurrent with frequent relapses. And earlier it was thought that it is like in developing country, we don't see it, but it's not so uncommon. It leads to painful and sight-threatening infection. The recurring part occurs in the stroma and the endothelial component of the cornea, and morbidity of the viral keratitis is through the corneal scarring and neovascularization. Affects the quality of life and patient is not experiencing active infection. And the important part of virus is that it just goes and is latent in the trigeminal ganglion, and with the proper trigger, when it happens, it comes back. So these are the different typical presentations of viral keratitis which we see. That this is a typical presentation which we get at dendrite, which is like in a tertiary care center, you see less of such cases. You see more of complicated cases. It's only the first contact patients presents things like that. And these cases, you may miss them if you don't see them properly, especially on oblique light. And only when we strain them, that this is when this typical dendrite comes out. And when you give them topical antiviral in the form of topical acyclovir, it heals beautifully in this form. The clinical presentations of viral keratitis we really have to see whether the virus is involving the epithelium of the cornea or the stroma of the cornea or both, or it is involving the endothelium or deep stroma or the uvea. So accordingly, the treatment differs. And once it is involving the epithelium of the cornea, it is usually infectious, and therefore we name it as an infectious epithelial keratitis. The presentations may be in the typical dendrite, or it may be a geographical or an amoeboid corneal ulcer. If it involves the stroma, which is actually usually an immune response to the virus in the epithelium, the presentation may be just in the form of disciform keratitis, or a necrotizing stromal keratitis, or an interstitial keratitis. Another way virus involves, it may be just simple endothelitis, and it may present with deep stromal edema. Herpetic uveitis is not uncommon, or at times you may have a keratouveitis. The typical thing about uveitis in herpes is that they have a very high intraocular pressure, and not uncommonly I've seen these patients are mistaken as cases of acute angle closure glaucoma. We have to be very, very careful when you're managing these cases. And of course, neurotrophic keratitis. So this is how a geographical ulcer comes out, and patients normally present to us in this kind of a manner when there is present a defect, and so you really have to see that where there's a defect, stain it, outline the margins, and see underlying stroma, because there might be a melting happening in that kind of a case. And these kind of cases, till the patient is not stain negative, you need to give them topical antivirals only. Or you may give them systemic antiviral, which we'll be discussing later, as the first course. There is no role of steroids at this stage. It's only when the ulcer starts responding, it becomes stain negative. That's the time when you add topical steroids, diluted steroids to begin with in QID form. So an ulcer starting from here, you can give them this kind of a picture later. But our problem is that patient may not come to us directly in this form. They come in a different mix and match kind of a form, and then you have to realize that what form of viral keratitis we are dealing with. So herpetic stromal keratitis is usually, as I told you, an immune response to epithelial disease. It's an immune response to herpes simplex virus, which is invading the anterior stroma, and there occurs or through the viral reactivation of the latent herpes virus in the sensory nerves. It may be non-necrotizing or a necrotizing inflammation, Not uncommonly, a necrotizing inflammation is mistaken as a fungal keratitis. I've seen that kind of thing also happening. And a non-necrotizing, when it presents to you typically in the form of a disciform keratitis, may be just missed as a simple corneal scar if somebody doesn't see it very clearly. Typical disciform keratitis has an intact epithelium, and it's maybe focal or diffuse, or it may be multifocal associated with uveitis, while a necrotizing stromal keratitis has actually real necrosis in the stroma, and you feel as if it's an abscess in the stromal part which is happening. There occurs ulceration and there is dense necrosis in the stroma. It may or may not be with epithelial defect. In necrotizing keratitis, HSV DNA has been isolated, and there may be cases when we get severe inflammatory response in herpetic stromal keratitis, and there may be a melt, which I've seen happening in front of me, and I really couldn't figure out what was happening, and with thinning and perforation. So this is the different pictures of stromal keratitis, which we'll go over. So you may get a stromal keratitis with this kind of a diffuse corneal edema. And in case it happens after a patient has undergone cataract surgery, sometimes it happens, patient is put on steroids, might have a mild nebulomacular opacity here, put on steroid, and then there occurs a reactivation. Patient presents to you like this, maybe third or the fourth week post-cataract surgery, and it may be mistaken as a pseudophakic bullous or maybe a localized descemet detachment. But you have to be very careful in these cases. So this I'm trying to show as one eye was like this, and this was the fellow eye of this patient. So the fellow eye patient had already had a graft. This was the second graft for this patient, and it's in the right eye patient presented to us like this. Hello. So for me, the diagnosis was very simple, that we are dealing with a case of a stromal keratitis. And if you really look at it, you will see fine capes on the endothelium. So these kind of cases, my line of treatment is to put them oral antivirals and give them topical steroids. And this is what when you ultimately lead to a scar formation in these cases. This is what I'm trying to show you is a necrotizing keratitis when the lesion may involve 6 to 7 millimeter. And you can see this dense yellowish kind of a look over here, and you may think that there is pus, but it's actually not pus.
Write a mail to me. Just write a mail to me so that it comes into the system.
And then once you have this kind of a localized area, and there might be irregularity, there's a lot of vascularization, they're chronic cases. And these cases respond very nicely to give them oral acyclovir, 400 mg, 5 times a day. In the acute phase, I like to give them. And this is what I've tried to show, that in acute phase, when put on oral acyclovir, how this central yellowish or the necrotic part starts diminishing and ultimately it disappears. So this is actually a direct infection of the corneal stroma with severe post-inflammatory reaction, where oral acyclovir is a boon. You may give a valacyclovir also, which we'll discuss later. There may be other presentation of viral keratitis. It is a diffuse kind of a stromal keratitis. There's a deeper layer of the corneal stroma which are diffusely affected, and there is no associated epithelial lesion. It's like deep keratitis, and they respond beautifully to steroids, topical steroids. This is what I'm trying to show you. The bugbear of viral keratitis is that it's the recurrence. So I have now patients who are following me for close to 15 to 20 years, and they know it because once they get the symptom, they come back. And this is one patient who has this kind of a lesion. He has this kind of a lesion over here, and other eye, of course, he's not seeing. And he keeps getting recurrences. Once he gets a recurrence, there occurs a local edema. He's used to have some kind of vision, maybe 636. And once this edema comes up, the vision goes down. And so that's the time for me to know that he has to be put back onto oral acyclovir. Because oral acyclovir, we normally put them up for good 6 to 8 months, 10 months. And patients sometimes ask you, when are they going to be off oral acyclovir? So this is the time, once they're off acyclovir, sometime later, they may come to you with recurrence. And this was, of course, a fellow eye of this patient, and there was no vision in this eye. So this is what I'm trying to show you, the recurrent multifocal kind of a stromal keratitis, in a sense that you may have one lesion here, then they may come up with another lesion here. So, and it's a very, very important to take your slit through those multiple areas as to see that where there is present scarring and in which area there is present edema. So the moment you get edema in a case which already has a scarring, you have to think that there is already occurring a recurrence in this case. Again, this was a one-night case whose vision fluctuates from 618 to 636. But the moment he gets gross edema like this, the vision goes down to finger counting 2 meters. But once we step up oral acyclovir, he comes back to his earlier vision. And since he's one-eyed, he doesn't want anything to be done to this patient. So this is another case I'm trying to show you. This was one of my case only, which I felt this is a recurrent stromal keratitis. And during the follow-up, he just came and said that his vision, this is the OD, right eye of the patient, and that the vision had gone down. And this is the time when, though on my routine slit lamp, I didn't find anything, but on staining, I could find another dendrite coming in. So this is the time when I had to really put the patient back on oral acyclovir, and ultimately the lesion healed. So they are actually chronic cases, and you have to be keeping really a hand on the pulse for these patients all the life, actually. This is another case I'm showing you of a typical herpetic endothelitis, where it's an immunological reaction to virus in the endothelium. And it's whether it's a cytolytic effect of virus on the endothelium, we don't know. And they also respond beautifully to oral acyclovir 400 to 800 milligram 5 times a day. In addition, we give them topical steroids. And this is also, I'm trying to show that there are multiple KPs. That is the hallmark that you are dealing with viral keratitis with. There might be a very mild edema in these cases. This is another case who had a multifocal done outside. And 1 month, as I was trying to tell you, within 1 month, the patient reported a diminution of vision. And she presented to me with this kind of a localized area with corneal edema. And the surgeon was very sure that nothing wrong had happened and she had regained the vision earlier. But basically, she had recurrence of viral keratitis, put the patient on oral acyclovir, and the whole lesion healed. The other form of viral keratitis could be in the form of a trophic ulcers or indolent ulcers. And you may get a small kind of a facet here, non-resolving. And herpetic viral infections of the ocular surface is a major cause for the development of neurotrophic. They may also land up with these kind of lesions, and they might be mistaken as geographical ulcers, but actually these are neurotrophic ulcers going on for a very long time, and underlying stroma opacifies, and they heal beautifully with tarsorrhaphy or increase in the lubricants in these patients. So this is how the ulcer resolves and will leave a nebulomacular opacity. So the common presentations I've already been telling you of viral keratitis is a combined presentation of epithelium and the stroma. So epithelium, you may have this kind of a lesion, a kind of a dendrite, and an underlying stromal edema. So you have to evaluate which layer of the cornea is effective, and then accordingly utilize your therapeutic modality. And this is another thing I want to tell you, that if suppose there are cases in which you may get some stromal opacity, and at times, we being corneal surgeons, at least I am not very, very forthcoming in doing any surgery in these patients, or even a corneal graft is never my first priority in these cases. But suppose these cases, one lands up and doing a simple cataract surgery. In this case, I did a cataract, I did a phaco in this case. But once the patient was on topical steroids, and antiviral I hadn't given because patient had not come to me as a case of viral keratitis. A small opacity was there. But during the follow-up, the patient landed up with secondary infection, and you can see a hypopion. So you have to really take these cases very properly. And this is another case which I want to show. This is one of my cases only who had a recurrent stromal keratitis. He had healed very nicely, and he was maintaining a vision of 624 actually. And you can see this was a scar, and he was following up very irregularly. Once during the follow-up, I noticed a small area coming up, which had taken up a stain. There was edema, and at this time, I had put the patient. I had stepped up the oral acyclovir, and with this, when I followed up, he showed no improvement at all. Rather, he worsened. And over the period of time, they developed a lot of vascularization. I wasn't sure what I'm dealing with. And this is the way you can see from this cornea, the cornea has worsened. A lot of vascularization coming up. And even he got a secondary infection meanwhile. And this is the time when I treated the patient with antifungals. and finally took him off, and now he's only on valacyclovir. And I don't have his latest picture over here, but the cornea has cleared a lot after this, and he's again come back to 660. So it's very difficult to really know what's happening in these cases. And this is how we have applied the different studies, the hepatic eye disease study, which really played on the role of topical steroids. It said that topical steroids significantly improve the stromal keratitis vis-a-vis a placebo, and oral acyclovir, the biggest benefit which we got from heads was the use of oral acyclovir. Maybe at that time in US, topical acyclovir was not FDA approved, though now it is approved. At that time, they said that oral acyclovir is beneficial in early resolution of stromal keratitis when used as an adjunct, 200 milligram 5 times a day. Statistically, they did not find any significant results, and it is always to be used as an adjunct to topical steroid therapy in stromal keratitis treatment. Then oral acyclovir was found to be beneficial in the treatment of iridocyclitis with topical prednisolone and TFT. So how do we apply this in our scenario? I will come to it later. In heads 2, they said there was no additional benefit of 3-week course of oral acyclovir in preventing stromal keratitis or iritis. We very often see cases present to us with initial typical dendrite or epithelial keratitis, and then sometime down the line they present with stromal keratitis. So they said that there was no additional benefit if you give them oral acyclovir in the case of epithelial keratitis. But important role was of oral acyclovir 400 mg BD for 1 year. It reduces the recurrence rate of HSV epithelial and stromal keratitis, which is like, now it's a 20-year-old study, but it is proven that oral OCV has definitely got a role in preventing the recurrence, and we are using it very commonly in our patients. And sometimes patients get sick of it and ask, when are you going to stop it? But once a patient is on oral acyclovir, it becomes almost a lifelong treatment. Triggers for HSV have been found that would be trauma in the form of surgery, as I've already told you, or any injury or any laser. I have had recurrence in my post-DALC cases. So if you are doing the DALC in cases of a simple, you think it's a simple corneopacity, surgery cases have gone absolutely uneventful, but still there was severe stromal edema in the follow-up. And later I analyzed that maybe I'm dealing with a case which is of a viral keratitis. Because when the case comes to you at that time you simply have corneopacity, you don't have any means to know you're dealing with viral keratitis. The treatment options are topical TFT, topical acyclovir, which I firmly believe is a first-line treatment. And I resort to 3% of it 5 times a day in active epithelial keratitis when the stain is positive. It has less of ocular surface toxicity. Of course, you have to be very careful. And it is, again, I have seen that cases of maybe granular dystrophy or recurrent corneal erosions or dry eye are sometimes mistakenly treated as cases of viral keratitis and given acyclovir, and it further worsens the condition. So you really have to know what you're treating with. Ganciclovir is another new drug, and well, nothing is over the acyclovir, and oral medication is preferred to avoid ocular toxicity from topical therapy. And this is another drug I'm talking about, a valacyclovir. Valacyclovir is a newer antiviral pro-drug. Acyclovir per se has a very short span. Bioavailability is very less, and so therefore we need to use it 5 times a day. Valacyclovir, we need to use it 3 times a day. It may have a better ocular penetration, and the dose is 1 gram 3 times a day. While if you use oral acyclovir in active stage, when I use 400 milligram 5 times a day. So these are the need for the use of systemic antiviral in hepatic eye disease. He says antivirals, they prevent the recurrent episode of hepatic stromal keratitis. It has low absorption, therefore it is frequent dosing is needed. Valacyclovir is an alternate to acyclovir. There is, as I said, higher bioavailability of valacyclovir with respect to acyclovir. So this is how the dosing has been combined. If you have 800 milligram acyclovir 5 times a day, it is equivalent to 500 milligram of valacyclovir 3 times a day. And 400 of milligram of acyclovir BD when we use in a prophylactic dose, equivalent of that is 500 milligram valacyclovir once a day. So a lot of my patients nowadays are on oral valacyclovir OD 500 milligram. You also have famciclovir also available, which is 250 to 500 milligram orally 3 times a day. So there's another drug which is ganciclovir, and like topically it has been used, and it doesn't give you any another added benefit over acyclovir. It is comes in the form of 0.15% topical active ganciclovir gel is available. Only advantage of this is to be used 3 times a day, unlike acyclovir, which is used 5 times a day. Whenever we do PK in a case of hepatic keratitis, you have to be careful that these cases are more prone to get glaucoma, graft rejection, and disease recurrence. And as I said, that herpes is latent. There are latency associated transcripts which are there, which maintain the latency of the virus. They do not let the virus to be encoded, and it is involved in the neuronal survival and suppression of apoptosis. So there are a lot of research going on the working of getting the LATs there so that the virus stays latent. So we need to have a proper balance as far as the diagnostic is concerned, as far as the use of topical or systemic antiviral is concerned, topical steroids are concerned, topical antiglaucoma, lubricants, dosage of systemic antiviral, and acyclovir or valacyclovir, and surgery. So when we use a proper balance of all these things, you really have a viral keratitis which is treated very well. Thank you very much. Thanks for your patience.